atheromatous plaques in the coronary artery circulation, then that stress of bad news, that adrenergic stimulation leads now to plaque rupture, and then now you have thrombosis, and they end up dying with a heart attack. So that's what this statement means. So let's look at ischemic heart disease, which we've said is the most important clinical manifestation of atherosclerosis. If in an exam we ask you about the risk factors of ischemic heart disease, they are the same as those of atherosclerosis. So you talk about modifiable and non-modifiable risk factors. They're the same. You can go and read also in Robbins. So ischemic heart disease by itself is a broad term that describes myocardial ischemia that results from an imbalance between cardiac blood supply and myocardial oxygen and nutritional requirements. What are the causes of ischemic heart disease? The commonest cause is coronary artery disease, to the extent that ischemic heart disease is usually synonymous with coronary artery disease unless otherwise stated. Like, for example, if you find it in a child. But in majority of the patients, ischemic heart disease is because of atherosclerosis. You can also have ischemic heart disease due to increased demand. For example, where you have an increased heart rate, like for example, in patients who have hyperthyroidism and their heart beats very fast, so they can get ischemic heart disease, or in patients who have hypertension. And the effects of hypertension. Hypertension causes hypertensive heart disease, which increases the demands of the heart. You learn about it in your next lecture. Ischemic heart disease can also occur where you have diminished blood volume. That can occur when you have a very low blood pressure or in shock. It can be cardiogenic shock, it can be hypovolemic shock, whichever, that leads to diminished blood volume and the heart suffers. Or you can have diminished oxygenation. So you have blood supply, but there's no oxygen in that blood. For example, in patients who have pneumonia or those who have congestive heart failure, or where you have diminished oxygen carrying capacity, for example, in patients who have anemia, or in patients who are suffering from carbon monoxide poisoning. This is one of the reasons why they die. So what is the pathogenesis of ischemic heart disease? You have atherosclerotic. So we've said it's synonymous disease unless otherwise stated. So where you have atherosclerosis, you have atherosclerotic narrowing that can affect any of the coronary arteries. For example, your left anterior descending, your left circumflex artery, or your right coronary artery. Please go back to your anatomy. It can affect this either singly, so you have one blood vessel affected, or you can have multiple of these blood vessels affected. Then you develop unstable angina. We're going to discuss this infarction and often sudden cardiac death that will occur because of your abrupt plaque change followed by thrombosis, what we've discussed. If you have, let's say, rupture or hemorrhage, then you're going to have this plaque change that leads to thrombosis, and you get occlusion of that coronary artery. So these changes, like we've said, include rupture, fissuring or ulceration that lead to thrombosis and occlusion of these blood vessels. In addition, you can have hemorrhage into the core of the plaques that can expand the plaque volume, thereby acutely exacerbating the degree of luminal occlusion. We've discussed the clinically significant plaque changes. So when they occur now in the coronary circulation, they now lead to ischemic heart disease. These acute plaque changes result from intrinsic and extrinsic factors. So intrinsic factors means what is affecting the plaque that is within the blood vessel. So we said unstable plaques are usually not a good plaque to have, because by the fact that they are unstable, they easily rupture. So you can have an unstable plaque. Then you have external factors. That's why I was saying that majority of the time, these atheromatous plaques are usually silent until they're triggered by an event. So what we are referring to as your extrinsic factors. For example, now where you have adrenergic stimulation that puts physical stress on the plaque, like for patients who have hypertension, or in cases of intense emotional stress. Okay, yeah. So someone has received bad news, they had an unstable plaque. So that adrenergic stimulation leads now to plaque rupture, and you have thrombosis, you have occlusion of the blood vessel, and this can lead to ischemic heart disease and even death. So in a majority of the cases, the vulnerable culprit lesion in patients who suffer an MI was not critically stenotic or even symptomatic before its rupture. Yes, it was growing, but it had not reached 70% occlusion for it to say that it is at the critical stenosis zone. It was just there. Then you had extrinsic factors that led it to become clinically apparent. So how does ischemic heart disease present? So ischemic heart disease presents in one or more of the following cardiac syndromes, and we're going to discuss each one of them. I'll pay close attention, or I'll discuss more on the myocardial infarction, and then we'll discuss the rest. So the first presentation is what we refer to as angina pectoris. So when you're asked to discuss cardiac syndromes, you start with angina pectoris. So angina pectoris refers to chest pains due to ischemia that is insufficient to cause myocyte death. Yes, you have reduced blood flow, but this has not reached the point of myocyte death. This is now the stage where we refer the critical stenosis we were referring to. So angina can be stable. So in stable angina, it occurs at certain levels of exertion or on increased demand. For example, someone is just when they are performing normal activities, they're okay. But when they climb the stairs, they complain of chest pains. So they have certain levels of exertion, or they lift something heavy because there's increased demand, then they start having chest pain. That is what is referred to as stable angina, and it occurs due to more than 70% stenosis, the critical stenosis we talked about, and it's usually relieved by rest, or you can give these patients a vasodilator, for example, your nitroglycerin. So if you have a patient who complains of chest pains during events of exertion, they most likely have stable angina. The other type of angina pectoris is what we call presmental angina, and this occurs due to vessel spasms on or near existing atheromatous plaques. So you have spasms, or it can also occur in normal vessels, and this usually responds to vasodilators and calcium channel blockers. So presmental angina can also occur in normal vessels, so it's not necessarily related to atheromatous plaques. Then we have unstable angina, which occurs with progressively less exertion or even at rest. So you have someone who's just seated and they are complaining of chest pains, and this is usually associated with greater than 90% occlusion, and you can have plaque disruption or superimposed thrombosis, and this is one of the bad anginas to have, and this will most likely require treatment. The other cardiac syndrome that is a manifestation of ischemic heart disease is your acute myocardial infarction, what patients refer to as heart attack, and this occurs in cardiomyocyte death. Remember, in angina pectoris, you have chest pains due to ischemia, but this is usually insufficient to cause myocyte death. But now when you enter into acute myocardial infarction, now you actually have ischemia that has led to cardiomyocyte death. So acute myocardial infarction is necrosis of heart muscle resulting from ischemia. And the major underlying cause of ischemic heart disease, we've said, is atherosclerosis. It is important to know that MIs can occur at virtually any age, but the frequency usually rises progressively with increasing age and with increasing atherosclerotic risk factors, which we have discussed, age being one of them. We said gender, males, but for postmenopausal women, the risk is the same because of lowered estrogen levels. Those who have hypertension, those who have diabetes, smokers, those who have hyperlipidemias, those who have inflammation, those who have high levels of lipoprotein A, those who have metabolic syndrome, all this constitute or increase the risk of an acute myocardial infarction. So how do you develop acute myocardial infarction? Usually results from acute coronary artery thrombosis in a pre-existing atherosclerotic plaque, though it can occur in other causes. For example, you can have coronary artery vasospasms, you can have spasms, or you can have embolization. So you have clots coming from other vascular beds. Like, for example, you can have a neurothrombi that occurs in atrial fibrillation. Neurothrombi is a clot that forms within the heart chamber. Then when you have atrial fibrillation, the clot dislodges and can lodge into any of the coronary arteries. Or you can have valve vegetations in patients who have infective endocarditis. This is one of the lectures you're going to have subsequently. It can also occur in patients who have vasculitis, amyloid deposition, or in stasis that can be seen in, for example, sickle cell disease. But the main cause of acute myocardial infarction is thrombosis in a pre-existing atheromatous plaque, but there are other causes. So what happens? So you have, what are the sequence of events in a typical myocardial infarction? And this is a myocardial infarction that is occurring where you have an atherosclerotic plaque. So you have atheromatous plaque changes that we've discussed. This can be rupture, erosion, or intraplaque hemorrhage, exposing subendothelial collagen. Then with that, you're basically exposing thrombogenic material. Then you have platelet adhesion, aggregation, and activation. You have activation of the coagulation pathway, which we discussed in detail in the first semester. You can go back to those notes. Then you have thrombus formation within minutes in this coronary artery. Then you have occlusion of your coronary artery lumen. And this can be revealed by angiography within 4 hours of onset of an MI in 90% of the patients. But if you do an angiography later, of course, where there's a clot, there's also the dissolution. We talked about fibrinolysis. But when you have now occlusion of your coronary artery, then this patient presents with a myocardial infarction. The goal of treatment is usually to dissolve this clot or to put in a stent. This is why they do angioplasty. You can put in a stent immediately to try and widen the lumen so that the heart can have adequate blood flow. So where you have vascular occlusion, of course, you have cessation of aerobic metabolism. So you have vessel occlusion, you're not supplying oxygen. So aerobic metabolism is compromised. This leads to reduced ATP. So where you have reduced ATP, where do you go? You go into anaerobic metabolism that leads to accumulation of noxious metabolites in cardiac myocytes. You can go back to our lecture on cell injury. Most of these changes are usually reversible if blood flow is restored And this is usually the goal of early diagnosis, thrombolysis, and angioplasty. So, early diagnosis, you are able to restore blood flow and reverse these abnormalities. But if you're not able to do that, then you have and you have ischemia that lasts more than 20 to 40 minutes, then you get irreversible damage and you get cell death, and this leads to coagulative necrosis. Go back to our lecture on cell injury. Where you have massive myocardial damage, this can result in arrhythmias, and these arrhythmias, particularly ventricular fibrillation, which is the commonest, will lead to sudden cardiac death, and this occurs in 80 to 90% of the patient. The purpose of this is to show you the various layers of the heart so that you can understand the pathogenesis of ischemic heart disease. So the innermost layer of the heart is referred to as the endocardium. Then you have the myocardium, and then the outer lining of the heart is called the epicardium. So that subendocardial zone is usually the first to undergo irreversible injury, as it's usually the last to receive blood supply. The blood vessels that supply the heart are usually located around the epicardium. So by the time that blood diffuses from the epicardium all the way to the endocardium, that takes time. And that's why the endocardium is usually the last to receive blood and therefore more prone to infarction. So with prolonged ischemia, cell death involves the myocardium if the ischemia is not corrected. So now it moves to the myocardium. And without intervention, you will have an infarct that is transmural. A transmural infarct is an infarct that involves the endocardium, myocardium, and the epicardium. And a transmural infarct can develop within 3 to 6 hours. The location, size, and morphologic feature of an infarct will depend on what is the size and distribution of the blood vessel that is involved. Are you occluding a major vessel or those small branching vessels? What is the rate of development and duration of the occlusion, because you allow time for collaterals to develop? What are the metabolic demands of that part of the heart? Like, for example, the left ventricle that is charged with pumping blood to the rest of the body has a higher demand. Okay. Also, is this patient hypertensive? Is this patient pregnant? So what are the metabolic demands of the patient who's undergoing this condition? Then what is the extent of collateral supply? Are there other alternative blood supply, so that even if you occlude a blood vessel, there is an alternative blood supply, which I'll discuss. So we've talked about the endocardium being the area that is at high risk of developing an infarction, and it's the first to develop infarction. Then as the duration of this occlusion lasts, then the zone of necrosis goes on further to include the myocardium and then eventually to go into the epicardium. So you have a transmural occlusion. Sorry, this table is packed, but this table just summarizes what I was talking about, factors that will influence infarct formation. So we've said the size and location of the vascular bed supplied by the occluded artery. So, for example, if you have occlusion of the left anterior descending, that and where in the left anterior descending are you occluding? So then you will affect the left ventricle, you'll affect the septum. So that the size and location of the vascular bed is very important. Then the rate of development of the occlusion. We've said atheromatous plaques develop over time, and this allows for collateral circulation to form. Then duration of the occlusion. We've said it starts in the subendocardial and it will progress if the duration of the occlusion becomes longer. Then what are the myocardial oxygen demands? If there's increased demand, for example, in patients who have hypertension, this will worsen your ischemic injury. We've talked about collateral blood supply. So if you have good collateral vessels, this will limit the infarct size, the heart rate and rhythm. So if you have arrhythmias, this will compromise perfusion and also increase infarct size. Then the metabolic status of the myocardium. If you have a hypertrophied myocardium, or you have a previously ischemic myocardium, these are more vulnerable to new infarction. And you'll learn this especially in hypertensive heart disease, which is your next lecture. And then reperfusion, whether it's therapeutic or spontaneous, this can salvage the injury. But also I'm going to discuss reperfusion injury that can also occur when reperfusion is delayed. So the infarcts that form can be transmural, that affect all the layers of the heart. And this usually produce changes on your ECG, what we call STEMI, ST elevation, myocardial infarction. So you have ST elevation on ECG. Then for your subendocardial, which affect the inner third of the lining of the heart, they most likely will give you non-STEMI, non-ST elevated myocardial infarction. Then you can have microscopic infarcts that are not visible, and these are usually seen in small vessel occlusions, in patients who have vasculitis, or you have embolization from valve vegetations. I've told you learn about infective endocarditis, or where you have vessel spasms. So one of the tests that you do for patients who come to hospital with chest pains and you're suspecting that they're having a myocardial infarction is an ECG, an electrocardiogram. And you want to look at the ST part. So if it is elevated, you say that's a STEMI. If it is not elevated, then that's a non-STEMI. So this is what the normal, this shows it's like a heartbeat. You have P, Q, R, S, T. So this is what is normal on an ECG. When you have subendocardial ischemia, we said you have non-STEMI. You don't have elevation, but most of the time they can give you what is called ST depression. So the ST goes down. Or when you have transmural ischemia, then your ST goes up. So that's now a ST elevation. And this is what doctors will see in the acute and emergency unit when they do an ECG to try and diagnose. So you use this ECG changes plus some of the blood tests I'm going to discuss to give you a diagnosis of a myocardial infarction, and it's paramount. Why have I shown this image? To try and demonstrate the blood supply to the heart. You have the right coronary artery, you have the left coronary artery that forms the left anterior descending and the left circumflex artery, and this usually supplies the left ventricle. Then you have the right coronary artery with some of these branches that supplies the right ventricle. Why is this important? Depending on where the occlusion starts, then you can have either minor infarcts or you can have major infarcts. For example, if you occlude this artery somewhere like here, I hope you can see my cursor, then you can imagine that the whole entire left ventricle will not have any blood supply. If I occlude it in a small area like here, the part where this area transfuses is small. So the effects will depend on the type of vessel that has been occluded. So the epicardial vessels that are mainly involved in ischemic heart disease, you have the proximal left anterior descending artery, which usually causes 40 to 50% of all your myocardial infarctions. And your left anterior descending artery usually supplies the anterior wall of the left ventricle, the anterior 2/3 of the ventricular septum, and also the heart apex. So if you occlude this, you can imagine the extent of damage that you're going to cause. 15 to 20% of myocardial infarctions occur due to occlusion of the proximal left circumflex that leads to necrosis of the lateral left ventricle. You can see where the left circumflex is, and this is the left anterior descending. Then 30 to 40% occur due to occlusion of the right coronary artery, and this, of course, will lead to necrosis of the right ventricle because the right coronary artery supplies the right ventricle. The posterior 1/3 of the septum, the anterior 2/3 is supplied by your proximal left anterior descending artery. So the posterior 1/3 of the septum and posterior left ventricle are usually perfused by the posterior descending artery that can either arise from your left circumflex artery or your right coronary artery. I think this one, this posterior descending artery. So it can either arise from your right coronary artery or it can arise from your left circumflex. Circumflex means it circumscribes the heart. I hope, please go back to your anatomy. So the major blood vessels are connected by numerous intercoronary anastomoses, and that's why we're saying collaterals are very important. So with gradual narrowing, this gradual dilatation of the collaterals providing adequate perfusion. So the extent of collateral also determines the extent of your myocardial infarction. So what are the morphologic changes that will occur in the heart? So the appearance will depend on the age of the injury. Of course, where you have, this is the heart, is a solid organ. Therefore, you're going to get coagulative necrosis. And of course, we said in necrosis, you have resultant inflammation. Please go back on the lecture on cell injury. So it progresses from coagulative necrosis, then you get acute, then chronic inflammation, and then eventually you get scar formation. Remember, the heart is a permanent tissue and therefore does not regenerate. Therefore, you're going to have scar formation. So for a myocardial infarction that is less than 12 hours, these are usually not grossly apparent. For those that occur within 12 to 24 hours, after 12 to 24 hours, these infarctions get a red-blue discoloration. Within 10 to 14 days, this red-blue discoloration transforms into soft yellow tan areas. I have images to show this. And then weeks later, they form a fibrous scar. So this is, I know you guys take screenshots, but this is just a table to summarize what the time of infarction and how the gross appearance of the heart is going to be like. What are the microscopic changes that you would expect if you take a section of that part of the heart, and what are the key events that govern the presentation. So this is just a summary. We said you move from, but the most important to know is that you have coagulative necrosis, which results in acute inflammation, then chronic inflammation, and then of course you have healing by fibrosis, and you're going to have different appearances of this. So so we've talked about this 12 to 24 hours. You had this red-blue discoloration or the dark mottling. So this is what the image demonstrates. You have a fresh infarct with mottled appearance. So you can see the red appearance of normal heart tissue, and then you have this red blue discoloration of the myocardium. This is an infarct that's about 12 to 24 hours. Then we have an infarct that has stayed. This is about 10 days. So this is an image of your left ventricle wall, which has been sectioned lengthwise to reveal a large recent myocardial infarction The center of the infarct contains necrotic muscle that appears yellow tan, and then surrounding this is a zone of red hyperemia. So this part here, I hope you can see my cursor. This is a part of the infarct even here, and then surrounding it is this normal muscle. This is an infarct when it's 10 to 14 days. You can see these yellow tan areas. Then we've talked about, this is the red mottling that you see in the early hours. Then you form this white scar. So this was where an infarct was. And then now there's this scarring. So scar usually appears white. So this is an area of an old infarct. So how do patients with myocardial infarction present? So classically, they present with severe crushing substernal chest pains that can radiate to the neck, the jaw, epigastrium, or the left arm. That's substernal chest pain, and it's very severe. For patients who have angina pectoris, pain typically lasts several minutes to hours and is not relieved by nitroglycerin or rest, especially if they have unstable angina. In patients who have myocardial infarction, they have a pulse rate that is rapid and weak. They also have diaphoresis. Diaphoresis is basically excessive and abnormal sweating. They also present with difficulty in breathing, what is referred to as dyspnea. And if, depending on where this occlusion is occurring, they can present with cardiogenic shock. I think we discussed shock in the last semester. You can go and read on it again. Then when you take an ECG of these patients, you will see Q waves. We've talked about the ST segment. You're interested, is there ST elevation or non-ST elevation, which will tell you if it is ST elevation, most likely a transmural infarct. If it's a non-ST elevated infarct, then that's most likely a subendocardial infarct. And of course, you're going to have arrhythmias, especially if the infarct is occurring where heart rate generation occurs. Then you have laboratory diagnosis, which is very important, and it has to be timely because we've said early diagnosis and treatment can reverse the effects of the ischemia. So laboratory evaluation of the myocardial infarction is usually based on measuring blood levels of macromolecules that leak out of injured endocardial cells through damaged cell membranes. So some of these macromolecules include your myoglobulin, your CKMB, your cytokeratin, which is specifically for the heart, MB. And this CKMB usually rises within 2 to 4 hours of a myocardial infarction, and it peaks 24 to 48 hours, returning to normal within 72 hours. So if a patient presents with that substernal pain, you can order a CKMB. And if it is high, the chances are, and you also include your ECG changes, this is diagnostic of a myocardial infarction. But this was what was used long ago. There are also hospitals in limited, where there are limited resources, then CKMB probably is still being done. But currently what is done mostly is your troponins, and we have troponin T and I, which are more specific for cardiac tissues, and they usually rise 2 to 4 hours, peaking 48 hours. And the good thing about troponins is they usually remain elevated for 7 to 10 days. That's more reliable for diagnosis and monitoring of therapy. So if you diagnose a patient as having a myocardial infarction, you want to measure the troponins. Are they going down? Then that shows that the treatment is effective. If the troponins are not going down and instead they are rising, then it means maybe there's reinfarction or the occlusion was more severe than the doctors had anticipated. Also, long ago, we used to do lactate dehydrogenase, which is no longer done now. So troponins and CKMB usually have a high specificity and sensitivity for myocardial damage, and therefore are preferred for the diagnosis of an acute myocardial infarction. So what are the consequences of this acute myocardial infarction? You can have contractile dysfunction. So where you have a myocardial infarction that affects the left ventricle, this will lead to hypotension, pulmonary congestion, and pulmonary edema. And this can also lead to cardiogenic shock. Go and read on cardiogenic shock again. So one of the consequences is you get contractile dysfunction. So the heart does not contract. And for the left ventricle, these are the consequences: hypotension, pulmonary congestion, and pulmonary edema. You can have papillary muscle dysfunction. Papillary muscles are what open and close the valves within the heart. So these patients will present with, they can have, if the papillary muscles affected are those that control the mitral valve or the tricuspid valve, you can have regurgitation, or you can have insufficiency. Then we have right ventricular infarction, which leads to right-sided heart failure. And when you have right-sided heart failure, you get venous circulation pooling and systemic hypotension. I don't know, I think you'll have a lecture on heart failure. You learn about right-sided and left-sided heart failure. You can have myocardial rupture, which can lead to, so when you have a rupture of the myocardium, the blood that is within the heart goes into the pericardial space and you get cardiac tamponade. For myocardial rupture, there are usually several risk factors. So for example, if the patient is more than 60 years of age, if the infarct is affecting the anterior or the lateral wall for female patients, and for those who don't have left ventricular hypertrophy, and in the first myocardial infarction, they're more likely to suffer from myocardial rupture. Then the other consequence is arrhythmias, and in 90% of the cases, this will be worse in STEMIs, those that have ST elevation. You can have pericarditis, especially since you have an infarct, you have necrosis and you have inflammation. So that fibrinohemorrhagic inflammation leads to pericarditis. You can have chamber dilatation due to weakening of the necrotic muscle. So you have dilatation of the heart. You can have neurothrombi because you're affecting contraction of the heart. Then you have stasis, blood remaining in the heart, and you end up forming a thrombi. Then you can also have ventricular aneurysms and heart failure. It's important to know about reperfusion injury after myocardial infarction. And reperfusion injury refers to additional myocardial damage that occurs after blood flow is restored to previously ischemic myocardia. And it is usually achieved where you perform thrombolysis, so you give them drugs to dissolve the clot, or where you perform an angioplasty. This is they put a stent, or they do what is called a CABG, the coronary artery bypass graft. You can read more on it. So while reperfusion limits infarct size and salvages viable tissue, it can also exacerbate cell injury and cause necrosis or dysfunction of surviving myocardia. Remember, in ischemia, you usually have formation of reactive oxygen species. So when you're bringing in more oxygen, you lead to more formation of this reactive oxygen species. Also, when you're bringing in blood, you're bringing in inflammatory cells that also release more reactive oxygen species that now contribute to reperfusion injury. So this is just a table to summarize the mechanisms. So we've talked about formation of your reactive oxygen species. Where you have cell injury, of course, you have influx of calcium. Go back to our lecture on cell injury. You have myocardial infarction, you have inflammation, and also you have microvascular injury that contribute to reperfusion injury. You can read more on this. For this, in reperfusion injury, the morphological appearance of the infarct is that you get hemorrhagic infarcts. So you have blood being restored in an area of infarction. Then you have contraction band necrosis, and you have neutrophilic infiltration. If you look at this in a microscope, and this is just an image to show you, these are hemorrhagic infarctions that are typical when you have restored blood supply in a previously infected tissue. So remember, I talked about cardiac syndromes. So we talked about angina pectoris. I have dwelled on acute myocardial infarction. Then the other cardiac syndromes are your chronic ischemic heart disease with congestive heart failure, where you have progressive ischemia, eventually precipitating mechanical pump failure. So if the ischemia is chronic, then you end up having heart failure. The other syndrome is your sudden cardiac death, which occurs due to tissue damage from either myocardial infarction or lethal arrhythmias. So the term acute coronary syndrome is applied to any of the three catastrophic manifestations of ischemic heart disease: unstable angina, which we've discussed, acute myocardial infarction, and sudden cardiac death. You can read on other causes of sudden cardiac death other than a myocardial infarction and arrhythmias. I think that's my last slide. Any question?